Good afternoon and welcome to Medicaid Health Plans of America's weekly webinar Wednesday series. This week's webinar, entitled Your Captive Audience, Engaging Members in LTPAC, is hosted by MHPA Business Associate Member PointRight and will be presented by Pamela Gould, Vice President of Business Development and Payer Strategies with PointRight. Today's webinar will be moderated by Julie Bastine, Senior Director of Marketing with PointRight. It's no secret that your most expensive and highest need members are those receiving care from a long-term post-acute care provider. What steps can health plans take to ensure their members are receiving the most efficient, effective, and reliable care in these settings? This session addresses how to utilize real-time, clinically based analytics to not only identify high-risk members in LTPAC settings, but devise successful strategies for engaging them in wellness programs such as fall prevention, smoking cessation, influenza vaccinations, and behavioral health. We will also provide examples of how to build high-performing LTPAC networks with standard performance measures that are based on clinical practice by diagnosis group rather than overall 5-star ratings. Data transparency and standardization enable payers to foster collaborative partnerships with LTPAC providers and tailor care management programs to fit the needs of a specific member. In turn, the plan is able to keep costs down with fewer readmissions and more satisfied members. Let predictive analytics place your members in the right care setting at the right time. Today's learning objectives of this webinar are the following: to utilize real-time, clinically based analytics to drive proactive care interventions for LTPAC members, align the unique needs of members with facility capabilities, and create high-performing partnerships with LTPAC providers using standard key performance metrics. And before I turn things over to today's presenter, I just want to remind attendees that you are in only mode. So if you do have questions, please type them into the question box on the control panel on the right-hand side of your screen. And we will either hold questions till the end, and depending on priority, our moderator, Julie, will answer them on the spot. And if you have further questions, please contact Pam Gould, who will be presenting today's webinar, or feel free to email me. That's sswango@mhpa.org with questions as well, and I'll forward it to the PointRight folks. So without further ado, I'm going to turn things over to Pam to take it away.
Hi, Sarah. Thank you so much, and thank you for everyone on the phone today for joining us. Just one disclaimer, I'm at the tail end of a cold, so if you hear me mute, it's because I'm having a coughing spell, and I'm going to work through it. So no worries there. But do feel free to ask questions. We're going to try to move this along. I'll give you some time back on your calendars at the end of the presentation. But do want to really touch on the key areas that Sarah has mentioned. So what we're going to cover today is the trends in long-term and post-acute care, what we're seeing, using real-time clinically based analytics, much as Sarah had teed up, to drive proactive care interventions for your long-term and post-acute care members. And then how do you align your members' care needs with the capabilities of your long-term and post-acute care providers, while at the same time creating a high-performing partnership with these providers. So doing that through key performance metrics, and we'll talk about P4Q, P4P programs that you may be developing. So just diving in a little bit, let's talk about some of the trends that we're seeing. So we see a lot of variance in long-term and post-acute care costs across the country. In fact, it accounts for 73% of the variation that we see overall in Medicare spend. And we also know that 70% of a health plan's highest cost members will pass through post-acute each year. And also, about 42% of the Medicare fee-for-service patients are discharged to a post-acute care setting after hospitalization, so pretty significant. And then when we look at dollars, we know that readmissions cost the healthcare system between 30 and 40 billion annually. So some pretty big numbers. We're also seeing an increase in the use of post-acute care. Between 2008 and 2013, the percentage of Medicare beneficiaries discharged from a hospital to a post-acute care setting increased by 4.5%. Again, very significant numbers. And then let's talk about the aging America. Another consideration is if we look at the baby boom generation, it's expected to fuel a 75% increase in the number of Americans over 65 requiring long-term care. What that means is there's an anticipated increase of roughly 1 million long-term care participants that we will see in skilled nursing facilities by 2030. So it's kind of mind-blowing when you think about it. The average cost for the long-term care patient in the U.S., and these are statistics, but they average roughly plus or minus $217 per day. Another thing that we're seeing is the number of health plans, and many of you on the call today are at risk for long-term care costs, a new market that we've entered into, and we're seeing this number increasing through duals and MLTSS programs. So it's really imperative that you drive collaboration with downstream providers to really keep these costs in check and manage these members in a positive manner. So that's where PointRight can be of help. What we do at PointRight is we inform our long-term and post-acute care stakeholders with actionable data. We've had over 20 years of experience using data to improve quality in these settings. And over that time, we've been able to collect 45 million plus identifiable minimum data set records, which are assessments. We'll talk a little bit about them as we go through the program, that help to drive our data sets internally. And they're used to generate very robust analytic solutions for measuring and monitoring the patients that you're treating in long-term and post-acute care. Two of the solutions that we have are endorsed by the National Quality Forum for rehospitalization metrics. And we actively monitor and measure 15,500 skilled nursing facilities. We actually work directly with 2,000 skilled nursing facilities that are using PointRight solutions and over 200 acute care providers. And then in 2014, because of clients approaching us and requesting information, we expanded our market to include managed care organizations, accountable care organizations, and hospitals. So let's talk about obtaining the data. In particular, why long-term and post-acute care organizations partner with PointRight. So one of the reasons they work with us is to help improve the accuracy of their MDS assessments. So one of the tools that we provide at PointRight is called a data integrity audit. And what this does is it allows the facilities to send their minimum data sets to PointRight. They're run through the data integrity audit to check for any type of discrepancies within the record. So if you're familiar with minimum data set, it's filled out by multidisciplines. It's not unusual to see discrepancies where perhaps one person coded that the member needed assist of 2 for a particular task, another person coded that they were independent. This would be a discrepancy that would be seen. We identify this, we turn this around in seconds, get it back to the facility, and the facility is then able to intervene on that. So they can then make changes before submitting the final record to CMS. And why this is important is that the MDS data drives the RUG rates for the SNF, which is basically how they're reimbursed. We also help them with improving the management of their patients through descriptive and predictive analytic solutions. In a nutshell, we're able to take their aggregate population, everyone that's in their building, and help them to look at areas where they can improve staff allocations, care interventions, their facilities' performance, their care quality metrics, and even identifying their best practices. What are they really good at doing? And then helping them drive better outcomes, reducing their rehospitalization rates, and even reducing their length of stay. And another piece that we do is helping the skilled nursing facilities with referral and revenue generation for market positioning. So in the event a SNF desires to participate in a downstream risk sharing, they're able to present standardized data that differentiates their services from that of their peers in the same market. Julie, I'm going to just stop for a second. Do we have any questions?
Sure. At this point, we just received a question that asks, do SNFs have metrics similar to payers for comparison of performance?
Yeah, it's a great question. And actually, yes, what we've done is we've tried to tandem our solutions so that what you're receiving on the managed care side for your health plan mirrors what the SNF is receiving, so that you're able to have comparison and very thoughtful discussions utilizing these tools. I'm going to move into some of the success that or the building blocks, and moving into how you build a successful post-acute care strategy, if there are no other questions at this point. Okay. So one of the first key elements to building a very robust and high-performing long-term and post-acute care network is understanding your members. You know, getting the information that's vital to you at the health plan when you're managing them. The first one, which sounds, you know, kind of obvious, but obviously very important, is where are they located and when did they arrive there? Another question, what therapy or therapies are they receiving? And are there any gaps in care that could be addressed while that member is in the facility? So really talking about how you're going to engage that member in the bed. So perhaps you could obtain a hemoglobin A1C if the member is diabetic and hasn't had a test done in the last year. Maybe a pneumococcal vaccine for your COPD or CHF patient. Influenza vaccines. Smoking cessation for the smoker who is maybe open at this point to discussing stopping smoking, and it's something that can be started at the facility in tandem with the plan. And then also antidepressant or medication management. If they are on something new or you're seeing a new condition, perhaps even involving behavioral health, creating consults, and really utilizing the skilled nursing facility as a base for intervening and integrating that care that you are able to deliver from the plan, as well as options that they have at the facility. You also want to know what adverse events they're at risk for, and how can they be mitigated or addressed during this stay. Another really important thing to understand is what programs can you initiate in the post-acute care space that would benefit the members that are discharging to home. So for example, a lot of health plans have nurse practitioners or SNFs, and really deploying these to your high-risk members and getting them involved prior to discharge can be key. Having palliative care and hospice discussions because you know a member is at risk for mortality. Involving them in medication reconciliation. Many health plans have programs where you're able to start that process or do that in the home. How wonderful if you can tee this up with a skilled nursing facility that may be doing the same thing and partner to begin that process before they even discharge. And then also, are they transitioning to long-term care and making those necessary preparations if that's the plan? So having a good grasp on where your member is, both geographically and clinically, can aid in early care engagement and improving the care integration. But let's talk about where some of this data comes from and the minimum data set. So for many of you on the call, you may be familiar with the minimum data set, and if you're not, what it is it's a standardized clinical assessment. It's required by CMS for all Medicare and Medicaid residents that are at certified skilled nursing facilities. It's a 38-page document, and it has over 500 data points that address the member's physical, mental, social functions, diagnoses, symptoms, and treatment. So it's a very robust, clinically rich document. And submission is required by CMS on days 5, 14, 30, 60, and 90. Or if they're long-term care, it's quarterly thereafter, and as well as upon admission, readmission, return to SNF, and at the start or stop of therapies. So if there's a change in condition, the minimum data set is often triggered. So let's talk about how you get this document. And some of you may be getting this document today. And what is the value of the document? How do you incorporate it in your overall care delivery and care planning? So PointRight, starting with our data sources, one of the key things we drive our analytic solutions from is the MDS assessment. But in addition to that, we add other data sources, including public domain data. So what we do when we typically work with a skilled nursing facility is we collect the minimum data set, and we will go back for about 2 years and collecting this data. This gives us a good history so we can help the facilities in managing their members, but it also provides us with additional information on members that may have traversed in and out of these facilities that we would have the examples and have the records of. When we work with health plans, what we do is we review your eligibility files, and we're then able to send through HIPAA-compliant platform information to you about your members specifically. So even though we're collecting the aggregate data from the facility doesn't have to worry about who they need to send to which health plan. We can take care of that piece. And because we do have data that goes back over 2 years, oftentimes we may have information on your members, especially if they're new to you or the plan, that you may not have been aware of. What we do on top of that is we build a platform of payer solutions. And these are what really differentiates us in this analytic space is that our payer solutions are using real-time clinical information versus retrospective claims data. The power behind that is that it gives you deeper insight into your member status that's not reflected on claims. So for example, where are they today with their ADLs? How are they doing with their pain? Engaging that member in the bed and really knowing what's happening today. So you're really empowering proactive versus reactive care management. The challenge of caring, and I'm putting on my care management hat from working with the payer environment as a care manager and also working in the hospital setting, is just having a lot of different sources of information and trying to tease it all out to understand the very key factors that I need to address. But I think we can all agree that understanding your members' risk factors and being able to mitigate those are going to be huge. They're going to help to drive better outcomes. They're going to help to keep costs down. The member's going to have a better experience. So you really need to get to the meat of what needs to be addressed. The sooner you're aware, the more involved you can be. So reviewing the MDS is vital. It can give you such key clinical information, and again, it's filled with a lot of robust data. So what we try to do at PointRight is help you to get to the heart of the usable information. Too often, if you're receiving the MDS from the state or you're getting it from facilities, maybe it's, you feel like this poor woman behind the desk. I know I did on many occasions where it's just daunting, and trying to go through a 38-page record can be very challenging at times. So one of the things we've done at PointRight is trying to make that a little bit easier, get to that usable information. What you're looking at is our dashboard. And the dashboard is a tool when you're working with PointRight. We receive the minimum data sets, and we're able to take the information from those documents and put it into this dashboard. The dashboard, as you can see, is color-coded. So it's color-coded by risk, and so your red would be very high risk, orange being high, yellow is medium, green is low. The other thing that we do is we put arrows in the boxes, as you see, which indicate if the member has had an improvement or a decline since their last assessment was done. If you take a look at this particular dashboard, what I'm circling here would be where your members' names would be located. And then if you go to the right, you can see where their assessment date was done. You'll see the facility that they're residing in or they are staying in for their short stay. You can see when they're admitted, what their level of care is. And here's where it gets really interesting. This is the usable information. These are your descriptive scales, as we call them, impairment scales. And basically what it is it's telling you what is going on with my member in that bed today based on the MDS. So I can see where they are with their ADLs and what their risk score is. I can look at their cognition, their mood, their pain. I can also go over here to the right to the predictive scales, and this is where PointRight's analytics come into play. Having all those minimum data sets in our database to be able to model and understand the risks that patients of this nature would be experiencing. And if I look, I can see members that are at risk for falls, pressure ulcers, hospitalization, mortality within 6 months, and return to SNF. The neat thing about this is any one of these categories can actually, if you click on them, you can sort them from high to low, low to high. So if you want to know really quickly what's going on with a member, we have a very nice tool that we actually just added to our tool not too long ago, after working with a managed care organization that requested it, is our complexity score. And what this does is, in a nutshell, it says based on what we're seeing across all planes of the MDS, this is the risk that the patient has and the complexity score that they're given. The higher the complexity score, the more that needs to be addressed with a member and the higher risks that they have. So it can really, if you were to sort this in order of high to low, it can give you some great information on who are those most complex members that are in facility today, I'm responsible for, that I want to get in front of and get out ahead of any event that might occur, like a pressure ulcer or readmission, before it happens. The other nice thing about this dashboard is if you're inquisitive and want to know a little bit more, you can drill down on any one of these buttons. So for example, let's say I wanted to know about somebody's ADL status. What I can do, and I'm just going to get through some of my programs, is I can click on that button and it will show me where this member is today for their ADL impairment scale. So for example, this particular member, I see that they're independent for eating, but I see that they need assistance for most of their other ADLs. They're also dependent for bathing and transfers, and they are using a wheelchair. They also have a limb prosthetic. So this gives me some information, especially if I'm approving therapy, I'd be looking to see that they're making gains across the continuum as they're being treated at this facility. If I want to understand their complexity score, I've pulled up an example that shows you some of the drill down that occurs when you pull up the complexity score. It gives you your patient's demographic information at the top, but the really nice thing is looking at all the different things that are causing this member to be at high risk. And these are the things that you can address while that member is in the bed, while you're engaging that patient to really, again, get in front of a lot of these events that could cause readmission or cause a member to fail upon discharge. If you're working on moving and rebalancing members from a skilled nursing facility back into the community, these can be things that you can address to understand better what do we need to have in place for support systems to know that this member will be able to successfully go back to living in the community environment. So let's put this into a case study. I thought I'd like case studies. I think sometimes they make it easier to understand. So we're going to talk a little bit about Beatrice. Beatrice is a 77-year-of-age female. She's widowed, and she resides with her daughter, who is single and does not drive. Beatrice has mild dementia, was admitted to Glenwood Skilled Nursing Facility after hospitalization for a fall and dehydration. At the house plan, the information you have on Beatrice indicates that she's filling her medications regularly. She has a diagnosis of dementia, a slight, mild. She's insulin-dependent diabetic. She has asthma, COPD. But you also know she's not had a physical in 14 months and that her daughter's her primary caregiver. And as you look at her costs, you see that the majority of her healthcare costs have occurred in the last 12 months have occurred due to her the medications that she's on. You also know that her MDS was completed on January 5th, and you're using PointRight solutions. So the care management team reviews the member's dashboard and notes Beatrice's admission to Glenwood. The care manager, upon reviewing first the complexity score, because she's busy, she's got a lot to do, wants to get right to the meat of it, she notes a few things. She sees that Beatrice has all the diagnoses that she's aware of, but also on here there's depression, inclusion of an antipsychotic medication, and an antidepressant. This is something that's new. She also notes that she's incontinent of bowel and bladder, and she's had a fall in the last 3 months, which is good to know because we know that she's been admitted and was hospitalized due to a fall, but we weren't aware that she had a fall in the last 3 months. We see that she's also on a therapeutic diet, which we might assume is related to her diabetes, but she's also on an altered consistency diet. So if she's getting any type of thickener in her meals or something is going on, why is that? Is it because of the diagnosis and the comorbidities, or is it something as simple as maybe loose dentures or dentition, something that could be addressed to help her to be able to eat better? So let's talk about what happens after this. The care manager then reviews Beatrice's member summary. And she notes Beatrice's MDS assessment also indicates that there is a new diagnosis of depression and antidepressant medication, new for the patient, that she has low impairment for mood and pain, which is good. She's got medium impairment for cognition, which we would expect. She's requiring assistance for all ADLs and is using a wheelchair. Again, to be expected post-fall, but also gives me an idea of where we need to go from comparison to her baseline. She's at low risk for mortality, but she's at very high risk for falls, pressure ulcers, and rehospitalization. Again, all of this information, usable data that you're getting just by going to your desktop. So based on the information that was noticed in the dashboard, the care manager collaborates with Beatrice's daughter, the care delivery team at the health plan, and Glenwood care delivery team. And the following occurs. A hemoglobin A1C is ordered. Beatrice receives a pneumococcal vaccine. A behavioral health referral is made and will occur within 48 hours. Beatrice is placed on a wound prevention program that the facility is running after the case manager dialogues with the care delivery team there. Beatrice is also enrolled in the plan's medication reconciliation and fall prevention programs, which is interesting because as they dialogue with the skilled nursing facility, they realize that they can start the medication reconciliation process there. So the team from the health plan will pick up and then follow Beatrice before she even goes home. Beatrice is also scheduled to be seen by the plan nurse practitioner or SNFist. The outcome in all of this was that by reviewing the PointRight dashboard, not having to go through a 38-page document, call a facility, get a verbal report, go through some timelines, the care manager was quickly able to determine Beatrice's location after her admission to the facility, understand the key clinical information from her MDS assessment that was vital to her care delivery, address risk factors and new conditions with timely and proactive interventions, and then engage Beatrice in some very valuable programs that both the health plan and the skilled nursing facility had while she was there at the facility. In addition, they were able to align the skilled nursing facilities programs, the wound prevention, medication reconciliation, with that of the health plan. The other thing they were able to do is direct the plan's clinical resources, their nurse practitioners and SNFists, and also close a few gaps in care while she was there. The biggest thing was the integration of seamless care delivery that's resulted in better communication and will have better outcomes for Beatrice. So I'm going to pause for a minute. Julie, do we have any other questions?
We don't have any questions at this time, but I would ask if you could go back to the screen that I believe showed the dashboard for the member summary.
Sure.
And the arrows. And there was a question that came through when you were going through there to just provide a little bit of more information on what the arrows indicate in the dashboard, the up and down arrows.
Sure. So what the arrows indicate is if there's been a change in that particular category in the member status from one MDS assessment to the next. So for example, in this case, we see an up arrow, so the member, we notice that there's been an improvement in their ADL status since their last assessment. If there's a down arrow, it means that they've had a decline in their status since their last assessment. So it's just a really quick way to drill down on, if you're looking at this dashboard every day, you know, which members am I seeing a quick change in so that I can get out in front of that.
And how often is this information refreshed in the system?
It's a great question. The information is refreshed as soon as we receive the MDS data. So as we get the MDS data from the facilities, we're updating the tools for the health plan.
Okay, great. I hope that answers the question.
If it doesn't, please text us and we can go back over it. So I want to talk a little bit about collaborating with downstream long-term and post-acute care providers. This is all really great to talk about. It's good stuff. But the key is really collaborating with those post-acute care providers and bringing them on alongside as part of the team. So part of that is building high-performing long-term and post-acute care networks. I think we're all very familiar with narrow networks. They're efficient, but they're typically geared towards the stakeholder, and they don't always do a lot when it comes to aligning the client's needs or the patient's needs with that of the skilled nursing facility. What we promote here at PointRight is high-performing smart networks, networks that are customized to fit individual needs and data-driven. So let's talk a little bit about that. So how do you collaborate with your SNFs? Building high-performing long-term and post-acute care networks is really something that a lot of people take different approaches to it. So as I've talked with health plans, we find there's some people using CMS 5-star measures. That works for some things, but we know that CMS 5-star measures really don't have a lot to do with readmission and various other things. So oftentimes they're not a true indicator of facilities that are doing well in certain areas. For example, a lot of times we'll see a CMS 1-star facility that may be excelling at a particular therapy and care delivery, but they get overlooked because they have the 1-star. We've had health plans we've worked with where they're in areas where they don't have facilities that are above 3 stars. So what do? So some plans develop their own spreadsheets and try to figure this out and look at the different networks and so on. Here's what we suggest, and just very simple, very easy to deploy, is using data on these facilities to determine your best practice facilities and having the data that you can access quickly to be able to develop, these networks. So in developing these networks, one of the things that we encourage is really understanding just that. What is the facility's best practices by clinical cohort? And how do I align my members? So if I know a facility is doing really good with COPD or doing really well with caring for asthma, how do I align the care delivery with that to my patients that would have these conditions? We can also give you analytics to drive P for P and P for Q incentive programs. So once you have that network built, how do I manage it? And how do I make sure that it's continuing to perform the way that I would expect or the way that I would hope based on the members I'm sending there? And also providing on-site care delivery programs, being able to integrate the health plans programs with those that are being provided at the long-term and post-acute care facilities. So care management, having that on-site, bringing in nurse practitioners or SNFs, even deploying telehealth. Being able to identify unique programs that the skilled nursing facilities may provide. Keep in mind, a lot of your facilities, especially if you have high volume or you're driving high volume to that facility from your health plan, they're in the community. So oftentimes they're doing things in the community you may not be aware of. They may have support groups, bereavement groups, Alcoholics Anonymous. Maybe there are programs that you can tap into or even sponsor and co-sponsor with the SNF once you have them as part of your network. So it's things to think about. The big thing we want to drive is integrating that care delivery with your network partners by promoting synergy through analytics. So where do you begin? So PointRight has a SNF scorecard, and our scorecard provides information on 100% of the CMS recognized providers in the U.S. So you can have data on anyone in the country. It does not require MDS data submission, and it utilizes predicted 30-day rehospitalization grades to rank the SNF's performance. And we do that by clinical cohort. So we identify those facilities that are doing well with COPD, CVA, heart failure, pneumonia, diabetes, hip, knee, and other surgeries. And then the SNFs are graded and benchmarked against each other within a selected comparison group. And you choose the group. You can compare by state, county, zip code, and as well as on a state and national level. So it allows you to have a better understanding of how your network providers are doing overall. Sorry, had to cough there. So what this looks like, I'm going to show you this, but before we do it, to kind of explain this a little more, what we're doing is we take analytics and you build a comparison group. So let's say you had a county that you're working with and you want to know how these facilities are doing against each other. Who are my best practice providers? You would then look at this county. We encourage that you have over 10 facilities as a comparison group. That's your minimum. And then what happens is we give them a median score. So how are they providing care as a group collectively? And that is given an assigned grade. How these groups, how these particular facilities vary within that median score is how they get a PointRight grade. So if they happen to be providing care that goes above the level of the median group, they're going to get an A or a B rating in that particular area. If they're well below the median score and not doing as well, they're going to have a lower grade. So this is what that looks like. And in front of you is an example of the PointRight SNF scorecard. And as you can see, it's very valuable. It gives you information on the individual facilities that are being compared in your group. And then here's where we give you that overall rating, that median score that is happening for that particular group that you're comparing. The other neat thing that we do is we give you a comparison. And having the state comparison can be very helpful because what you can see right away when you're looking at a group is you will be able to know, are they falling well below the care delivery medium for the state? If they are, this may be a group of skilled nursing facilities. If this happens to be a particular area you have to work in, you have members in this area, this is an area where you're going to be sending your members. Maybe you look at this group as being someone where you deploy some of those extra programs that you have or resources like nurse practitioners, SNFs, other types of things that can help bolster the care delivery in this lower performing group. The other thing that we give you is the national average. So the national average just helps you to see how they're doing collectively against the national players. And then we talk about the PointRight grades. This is where they get their A, B, C, D, E scores based on their variance from that median. And then here is the particular facility's overall grades. So the facility we're looking at has an overall A grade. They're doing very well. But if you look, there are two areas they're excelling in. They're doing extremely well with their CVA patients, and they're doing extremely well with their pneumonia patients. So actually, if I don't get any better, I may be checking myself into the skilled nursing facility. But it gives you an idea of when you're aligning care delivery, how do I match up conditions for my members with those high performers so that they will have better outcomes? And again, knowing that they probably have care delivery programs in place that help them to really excel in these areas that you can tap into. The other thing we give you is we do provide on this scorecard how they've done with their post-acute performance grades throughout the different categories: staffing, care processes and consequences, their quality measures, all the way down to consumer experience, which is very important, especially when you're thinking about your CAP scores, overall CMS 5-star scores and their ratings. And then to the right, this is really nice because it gives you intel on the facility specific. So it talks about their staffing. You can see what their RN to total licensed ratio is. You can tell how much of their care percentage is being delivered by assistants, CODAs, etc. For PT and OT, are they using contractors or are they doing that on site? You can also see if they have a full-time NP or PA there and how often the medical director, if they're on site more than 1 day a week. You can also, again, look at these other categories and how they break out for their quality measures, compliance, etc.
So Pam, before you move on, there was one question that came through. Someone asked, is there any information the health plan needs to provide for the scorecard since it does not use MDS data?
Okay, thanks, Julie. Great question. So no, really all we need from you is to understand what areas and comparison groups that you want to look at. If you want a particular state, you want a particular county, maybe you want several states. This is how we can configure the scorecard, and then once you have access to the scorecard, you can build your comparison groups as many times as you want in as many fashions as you want. So this is totally up to the plan. The other thing I didn't mention is that this scorecard is available in raw data. So in other words, instead of looking at this as a card, you can actually pull up an Excel spreadsheet that will have the list of the comparison group in there, all of these different information pieces. And so if you're doing something looking at a particular area for P for Q or you're looking at alignment and you just want to sort by a certain category, it gives you the ability to do that. So that's all embedded in this.
Okay, that's great. That was another question where someone asked, you know, they said that they have a existing program in place that evaluates skilled nursing facility performance, but they might be interested in a component of this data. So, you know, as part of our work.
Absolutely. Yep, you can definitely extract that information. So,
okay.
Thank you. So once you've identified who you are going to have participate in your preferred networks, then it becomes the challenge of managing your high-performing network. So one of the things that we encourage is once you have these networks built and you're starting to form these partnerships with your long-term and post-acute care providers, getting the MDS data is key. And then you can use the MDS data and PointRight solutions to be able to understand in real time what is the performance of these facilities. So rather than predicting the 30-day rehospitalization rate, we can actually calculate it using the MDS data. So we have a solution, we call it the Pro30. It is risk adjusted. It's a rehospitalization metric that's been endorsed by the National Quality Forum as well as the American Healthcare Association. And it provides analysis of those 30-day rehospitalization outcomes on similar clinical cohorts that we saw on the scorecard. It's just now we're looking more at real time based on the MDS. But it can be a really valuable tool for building as well as incenting for P4Q and P4P programs. What the tool looks like is this here. So you see, you're still seeing those same diagnosis groups and clinical cohort groups here. And then you see you have the ability to compare. So in this particular example, I have 10 facilities. If you count across the bars, you see that there's 10 facilities indicated in this area. And I have a choice. I can compare my 10 facilities by percentile. So I just want to see how are they doing amongst each other. And when I do that, I have the ability to set my cut points. So it's up to me to determine what I would consider good for readmission, what I would consider poor or in the middle. So once I set those parameters, these numbers down here are going to change, and all of the facilities that I have in this are going to basically be deposited where they belong based on how they're performing. I can also do this same comparison by percent. So just looking at one facility and what are they doing for that facility particular. So in this example, I'm showing where I've got 10 facilities. I have 9 facilities that you see that are kind of middle of the road here. I have one facility that's an outlier when I am looking at, in this case, it was CHF. So I wanted to know who my outlier was for CHF. If you look here, it was one facility. I click on that button, and what I get is a list of the facilities that I'm comparing, and I see who my outlier is. It's important to know, because if you've got someone in your network that has been performing really well, you've been monitoring them, and then all of a sudden, for whatever reason, you see a change, this is a time to get on the phone or go to the facility, have a thoughtful discussion. You can find out a lot of information. But before that, it's really kind of doing your due diligence to find out what information you can glean from the MDS. So if you were to click on this particular facility, what you would get is a trend and track report. This report shows that this facility, and much like the example I just mentioned, was doing really well. If you look at the national average, you'll see, so there's 3 lines here. The dark bar is the national average. The blue is the facility's observed rate. And the brown is where we've risk adjusted. So we're giving them a credit for the acuity of the members that are in their beds. But if you look across the plane here, you see that they were really doing pretty well right up until about November 2015 in this example. And then all of a sudden their numbers start to platform way up for readmission. What happened? So when I call the facility, I now have enough information to say, you know, I'm looking at your trend and track report, much like the question that was asked in the past, do the facilities have similar types of tools? They can, and if they have this tool, they'll see this as well, so you'll be sharing information that they're seeing also. And the question to ask is what happened in November? And you'd be surprised some of the answers you'll find out. Things like our director of nursing left. We were purchased. We went through a new acquisition and we have new ownership now. all of our policies and procedures changed. We lost a lot of staff. There's been a turnover. So there's a lot of different things that we can see in this particular tool, and it also allows you to drill down even further into noting days of the week where there's certain readmission, heightened readmission versus other days. So it's a very valuable tool in managing that network.
Pam, someone's asking if you can speak to the difference between the facility observed and the facility adjusted.
Yes, so that's the two rates here. So the observed is where the facility's raw data, where we have not risk adjusted the data for their acuity. So in other words, we're comparing apples to apples. A lot of times when you'll go to a facility and you share information with them and you say, you know, I see that you've had this trend in readmission since November. Well, you know what? I took sicker patients. Well, this is what we do at PointRight. We adjust for that. This is what we see here with the risk-adjusted score. So this isn't the reason this number spiked up is because you were taking sicker patients. I mean, you know, certainly that would play into it, but we are adjusting for that. So it really helps you to be able to see the true picture of what's going on. The other thing that we can share with plans, and again, looking at P for Q, P for P, or however you're managing quality, is looking at the quality measures within the facility. Our facilities use a similar tool. It helps them to be on track with their CMS quality measures and being able to understand how they're doing across the board in various areas with their quality of care. Very similar to the Pro 30, able to set similar cut points, able to see how the facilities are doing across the board. So it can also be a valuable tool when you are looking at managing the folks that you've now included in your network and making sure that they're continuing to provide the quality of care that you would expect from them. So with that said, that concludes our program, and I want to open it up for any questions there might be. As I said, you know, trying to give you back some time on your calendars as well. I all know that folks on the call are extremely busy, but we do appreciate your interest, and we certainly appreciate your questions. We are going to provide you, Sarah has given you my information. Please feel free to contact me if there's something that you'd like to discuss that's kind of outside of what we've reviewed today.
Thanks, Pam. Thanks so much. And as Pam mentioned, if you have any questions or if you want to circle back to something that she covered off on earlier in the presentation, please feel free to submit your question through the question box in the GoToWebinar meeting platform, and we'll get that answered. Or we've put Pam's information up on the screen for you as well, and you can send her a personal email or give her a call, and she'd be happy to explain or elaborate on anything that she's just presented today. Also, I believe that the folks at MHPA are recording today's webinar, so we'll be able to get you a copy of the presentation slides and the recording if you want to take another listen or drill into something in the slide deck. The last question, Pam, that came through shortly after the case study portion was around some of the work that PointRight's done to date and any kind of use cases or examples of some wins that some of our clients have seen utilizing some of these tools.
Great question. So, of course, as you know, we have a very varied group of managed care organizations that we work with. So each organization, depending on where they fall on the payer platform, has different goals. Sometimes one of the organizations we're working with, their goal is rebalancing. So really moving members from the skilled nursing facility back into the community. We've had a lot of success working with that organization in kind of just changing how the approach is as you go into the facility and identify what are the best members to discharge home. You know, it sounds like it would be fairly simple to do. You could send your case managers in and they could figure it out. But the reality is it isn't always that easy. And if you don't understand the members' risk factors and some of the things that can cause things to blow up later on down the road, and you don't address those, they certainly do blow up, and that's what was happening. So being able to identify, get out in front of that has helped that plan. There's other plans that we're working with where they are trying to drive better efficiency with their nurse practitioner and SNF programs, knowing where to send their physicians and their nurse practitioners. Again, these are very costly resources, and you don't want them just kind of being haphazardly deployed. Sometimes it's been very safe because they're embedded in I-SNP programs, and that works out well, and they can bleed over to folks within the facility. But as we see from the example in the complexity score, you may have members in facilities where you don't have these services, but you could very well deploy them if you know where your complex members are. And so when you start developing these really great relationships with these skilled nursing facilities, you know where you want to send them. In addition, we've had plans that have also said, I've also identified that the skilled nursing facilities I'm working with, they just don't have the resources. You know, they're lower performing in this particular state. I've got to use them. What can I do to help support them? So our analytics have really demonstrated, not only for them, but in tandem working with the facilities, how they can improve their overall care, their staff allocation, not necessarily having to add more staff or add more money, but just deploy the resources differently to provide stronger and better care. It really varies based on who we're working with, but those are some of the examples of how they're working with our solutions today.
That's great. Excellent. Thanks so much. And one question did come through that I just want to ask before we wrap up so we can give folks some of that much needed time back in their calendars. But what's the implementation timeline look like when working with PointRight?
Excuse me. Yeah, typically what we do, and of course it's going to depend on you know, areas that we're talking about, if it's a national project or if we're doing a state project. But typically we're looking at something between 30 to 60 days, depending on the solutions, the number of solutions, and obviously the depth and breadth of the project that we're working on. The SNF scorecard is something we can deploy pretty quickly. So, you know, if a health plan is interested, it's something that we're able to really get up and running in pretty quick time.
All right, that's terrific. Well, I think that concludes our presentation. Sarah, I will hand it back to you if you have any final comments or wrap-up remarks. Thank you, Pam.
Thank you.
Thank you, Pam, and thank you, Julie. Thank you, PointRight folks and team today for today's webinar. That was very insightful. Again, as Julie and Pam both said, the webinar information will be provided. We do have a recording of today's webinar available, and we will also send out the presentation should you request it. So feel free to contact Pam at the contact information on your screen, or always feel free to contact me, Sarah Swango, SSWANGO at MHPA.org with questions, and I will forward to the appropriate PointRight team member. So again, thank you for attending today's Webinar Wednesday, part of MHPA's Webinar Wednesday series, and stay tuned and check out our website, Medicaid.org, MedicaidPlans.org, for a list and lineup of upcoming webinars. Thank you again, and have a great Wednesday.